The standard treatment, R-CHOP or R-CHOP, is a very good and efficacious treatment for patients with lymphoma. And at least in aggressive lymphoma, we can cure a large number of patients. Now, there are two avenues that are interesting. One avenue is that you want to decrease toxicity, and let me give you an example of that. Anaplastic large cell lymphoma is a very aggressive form of T-cell lymphoma. And with the advent of brentuximab vedotin, which is an antibody-drug conjugate, where a CD30 antibody is coupled to a very effective drug, we have the possibility to A, increase efficacy for patients with that T-cell lymphoma, and B, possibly decrease toxicity, because vincristine that we're using now is a drug that is good, but the side effect polyneuropathy is, when you look at the quality of life, a very, very big impairment for patients who get it. The second avenue is that drugs that may save chemotherapy and toxicity of chemotherapy will become part of the lymphoma treatment. There are people who are already talking about chemo-free treatment in CLL and follicular lymphoma, which is a nice term, but of course the new drugs are chemo drugs as well. They do have their side effects. But the side effects and the long-term side effects of chemotherapy can be ameliorated if you decrease the amount of drugs that you need and if you consolidate. And the drugs that are coming onto the market, like ibrutinib, idelalisib, and similar drugs, will play a very, very important role. And our trial group, such as others, are trying to incorporate those into the strategies to treat lymphoma patients. And also, there are improvements on the antibodies. There are new antibodies, there are new antigens that are being targeted. There are maintenance strategies with antibodies, and I think the field is really moving rapidly. Also with the advent of companion diagnostics that are important. CAR T cells, that's a fascinating field, but it's very early in its development. CAR T cells have been around for a number of years as a concept, as a lab concept. Basically, there's only one group, the Philadelphia group, that has really succeeded in showing that CAR T cells, at least in ALL patients and in some DLBCL patients, are efficient. And what is the reason? The reason is that they have been able to show that CAR T cells remain in circulation in the body of the patient for a prolonged period of time, up to 3 years, so they can stay active. So the point in CAR T cells is you have to be able to stimulate and expand them, and you have to be able to keep them in the body for a prolonged period of time. And the Philadelphia results are really fascinating, and I'm thrilled to see when they come into clinical trials also in Europe, how we can apply them. If you go a step back, CAR T cells are basically a form of autologous stem cell treatment that are augmented by a specific antigenic effect. And that is a very, very fascinating field. And it's very easy to envisage that you can use CAR T cells to supplement or enlarge the effect of allogeneic stem cell therapy. Allogeneic stem cell therapy is still a very, very important treatment in e.g. aggressive T-cell lymphoma, aggressive B-cell lymphoma. We have shown in clinical trials that relapsed patients with DLBCL, the only chance for these patients in a relapse after R-CHOP to survive is basically allogeneic stem cell transplant. So we need the T-cell treatment. And CAR T cells may make this treatment even more specific. And with the advent of the haploidentical strategies that our transplant colleagues have been developing, there will certainly be a larger number of patients who may benefit from this. And in the end, if you then look at immunotherapy, not only at cellular immunotherapy, it's very easy to envisage that the PD-1 blockade antibodies that our solid tumor colleagues are using in lung cancer and other cancers, that they may be actually able to improve the treatment and efficacy of CAR T cells, of allogeneic stem cell treatment also in B-cell lymphoma. And we're starting the first trial in Germany this year with a PD-1 blockade antibody in relapsed DLBCL. And I think that's a great step forward too.